Hello, everyone. Thank you for coming. I'm Jonathan Lynch with CDC's Environmental Health Nexus. Today, we're hosting a workshop on applied epidemiology and environmental health. Next slide. Today's presentation will be available to view on demand approximately 2 weeks after this workshop on CDC's Environmental Health Nexus website. That is www.cdc.gov/nceh/EHSP/EHNexus. The roundtable discussions will not be recorded. Next slide. We ask that you remain muted throughout the presentation. Please use the chat window to ask questions of the panelists. Next slide. The content and conclusions in this presentation are those of the authors and presenters and do not necessarily represent the views of, nor should any endorsements be inferred by the Centers for Disease Control and Prevention. Next slide. Now I welcome Dr. Erik Svendsen, Director of CDC's Division of Environmental Health Science and Practice. Dr. Svendsen.
Well, thank you so much, Jonathan, and thank you to all of you for joining us today. We're excited about having this workshop and being able to share with you some really interesting topics that we think will really help you all do the work that you need to do in environmental public health practice across the country. So just a little background as to how we got here, and so why are we doing this? So from my background, I've worked at the state level, I've worked at the local level, like many of you, as well as at the federal level and in another agency. And many of the tools that we need in public health practice at those different levels, at the local level, in county or city health departments, or at the state level especially, many of the tools that we need to do the work that we have before us every day, it's a little bit different than what we typically get in the training that we have in graduate programs across the country in epidemiology. So we do a great job in training our epi grads in clinical epi, infectious disease outbreaks, disease surveillance, and if you're like me, you get some additional background and training in occupational and environmental epidemiology, but that tends to be focused more on looking at epidemiologic research and trying to identify new risk factors for different types of public health problems or health outcomes or diseases across the country. There aren't a whole lot of discussions or emphasis put on the methods within epidemiology to be able to assess public health patterns of disease that are associated with environmental health risk factors that we already know about. In other words, applied types of epidemiology approaches within the environmental health context. So to help address that challenge or gap in the typical training that I've experienced, and I would anticipate many of you across the country have experienced that same kind of gap. We talked to some folks across the country to identify some of the topics that would be of most interest to you all. So our health studies program here at NCEH reached out, had a survey, and developed the top 4 methods that were of greatest interest to our partners out in public health practice, and what you would really like to hear about within the types of applied epidemiologic methods that we can share with you, that the work that we do here at the national level, and help collaborate with other partners across the country and other agencies as well. So we're hoping that this is the first of several types of workshops where we can get into these methods in a little bit more detail, roll up our sleeves, and learn more about them and be able to apply them in the work that we do across the country. And the other side of it is we hope that this would also help folks in academia be able to teach this a little bit better. That was one of the challenges that I also had when I was in academia. I was looking around for ways to teach this stuff it was difficult and challenging because the resources weren't where I would have liked them to be. So hopefully this will help us fill those types of gaps in being able to help the people who are out there in public health practice right now be supported in keeping up with the science as they go, because, you know, I was there with you. It's really hard to keep up with science when you're out there doing public health practice every single day. And that's what we're hoping to help you all with today, is to kind of show the where are we right now in these different topics, and how can we help support you so you could do your work better in your jurisdictions. So today we're going to be talking about disaster epidemiology, cancer cluster methods, and then looking at ecologic studies or group level data, and lastly, spatial correlations. These are all topics that you all really showed interest in. So in disaster epidemiology, how do we get out there and get the right data fast so that we can make the right decisions? And so one of the methods that you're going to be hearing about today is related to that. And it's a method that was developed here at the National Center for Environmental Health many, many years ago. Another talk will be on cancer clusters and looking at the science of where we are in the analytics and capabilities and the methodologic approaches to be able to address the patterns of how diseases are distributed in space, and how do we say that that's a cluster or not. Ecologic fallacy is often talked about, and sometimes ecologic studies are even ridiculed, but they can be incredibly powerful tools when used appropriately to answer questions about group level data. And so group level inferences, population inferences, what's going on in my population, not necessarily the individual. So how do we use those tools appropriately to really make impactful decisions for our jurisdictions? And then lastly, how do we look at the patterns of disease and look at how exposures can be correlated within space, and how do we address that statistically? So we're excited about where we're going over the course of this workshop, and we're very thankful to Dana Flanders for helping us to be able to pull together this great series of speakers in our health studies program as well. So many thanks to all of you within our National Center for Environmental Health who have supported this, and many thanks to our speakers who are going to be speaking to us the next 2 days. So with that, I'd like to introduce our moderator, Dr. Dana Flanders. And Dana, it's all yours. The mic is all yours.
Great. Thank you, Eric. Yeah, I'm Dana Flanders, and I'll be moderating. I'm a professor at Emory, but I've worked with the National Center for Environmental Health and many of the people who are part of the planning committee for many years. So it's my pleasure to be in this role. Let me again echo what Eric said, and welcome to this CDC workshop on applied epidemiology and environmental health. And again, our thanks to the speakers who are giving their time and expertise to this effort. And we're glad that you've all joined us. So thank you for that. I'm very excited about our workshop. We spent a fair amount of time looking through the literature to identify the top people in the areas that had been selected to emphasize today that Dr. Svendsen, briefly discussed. And we were very happy that some of these top people were able to join us. I'll say a bit about each one at the beginning, each speaker at the beginning of their presentation, but I had to cut down the bio. We could have spent, substantial amount of time just talking about their qualifications. So I cut it back a bit to give them adequate time to speak. So our speakers today, the first day, are Dr. Jennifer Horney and Dr. Michael Goodman. Next slide, please. The agenda, the topics for today will be by Dr. Horney, academic, state, and local partnerships for primary data after disasters, CASPER and beyond. CASPER is a method that was at least partially developed here at CDC years ago, and it was modified after a similar survey technique for looking at polio vaccination coverage years ago. That kind of looking back at its origins, but she's going to take us up to date in CASPER and what's happening more recently. And then the second topic for today will be by Dr. Michael Goodman, Cancer Cluster Investigations, a few thoughts and suggestions. And he's written, he's published papers on these ideas, so he's going to share some of that with us. And then finally, we'll have two roundtable discussions later in the day. The first one at 2:15 and the second one about an hour after that. And this will be an opportunity to ask questions to each speaker on the topic. There'll be separate, one for Dr. Horney and one for Dr. Goodman. We ask that, as was said earlier, but we ask that you pose your questions using the chat feature of Zoom. And then I'll read the questions aloud for the speaker so that, they can be discussed and answered. Okay, next slide, please. So jumping right into it, today's first speaker will be Dr. Horney. Dr. Horney is a professor and the founding director of the Epidemiology program and core faculty at the Disaster Research Center at the University of Delaware. Her research focuses on measuring the health impacts of disasters, so obviously extremely appropriate. She's led interdisciplinary research projects funded by many federal agencies and has been part of the public health response to hurricanes Isabel, Charley, Katrina, Wilma, Irene, and Harvey, where she conducted rapid assessments of the disaster impacts on individual and community health. So Dr. Horney will share some of her expertise and experience with us today. Very excited about this. So I turn it over to Dr. Horney so she can share her slides and begin.
Thank you so much for the introduction. I'm so excited to be here and talk about this topic, which is near and dear to my heart. So I want to sort of just set the stage, and I know that these are conversations that probably no one who's on this call needs to have, but just to put it on record that we acknowledge that we're coming to this at a really critical time. We have to do a better job of understanding what the health impacts of disasters are, because the disasters are stronger, they're more severe, they're more frequent. So I use this slide frequently and check to make sure I was accurate, and I think that they are. We've had 4 of the wettest tropical cyclones on record to impact the United States since 2017. So it's not just an anecdotal sort of thing to say more frequent, more severe. It's backed up by data. I think no one needs to be told that we are also having hotter, more frequent heat waves. So as of July 20th, more than 100 million people in the United States were under heat warnings, and there are simultaneously heat waves around the globe impacting Asia, Europe, and the Middle East. And we also know that we're coming to this problem from a belief that, a knowledge that there are inequitable impacts of these types of disasters and public health emergencies on vulnerable populations. So this is just one example. We could give many, many examples. This is work after Hurricane Harvey in Houston, which basically shows that the higher the proportion of non-Hispanic, Black, and Hispanic residents, as well as the higher the proportion of poverty in a census tract, the more likely and more extensive the flooding would be. So we know this, but again, just to call it out directly and be on the same page. This is actually here in my relatively new home, Wilmington, Delaware. This was Hurricane Ida. So this was, a relatively moderate hurricane that had tremendous impacts in the northeastern part of the US on sort of the backside. And, we saw those consistent patterns again, that the poor neighborhoods in the city have more impacts from the flooding and access to fewer resources to recover. And so I'm coming at this with the perspective that environmental justice is just an integral part of what we are planning for and preparing for, and also the types of data that we are collecting post-disaster to assess public health impacts. And finally, this is I didn't go get the brand new data, but this is from February. I think that many people at least would like to believe that COVID has really drawn this to the fore with the recognition of the inequities, particularly in disease severity and outcomes. And I think while COVID is unique, it's similar in more ways than we've probably had time to explore to other types of public health emergencies and disasters, in that the severity in COVID, where they're thinking about hospitalizations or ICU or ventilator or death, really could map on to the more severe impacts from a disaster like a hurricane, and people being perhaps more likely to have home damage or to have job loss or other factors. So I think that COVID is unique, but it's sort of too easy for us if we try to say, oh, it's so unique that we can't apply any of the lessons learned to the rest of what we're doing in disaster epidemiology. So the flip side of this calculation is that there's also inequitable access to interventions, and whether that is a high quality hazard mitigation plan or whether that is a COVID vaccine, the fact remains that we have this intersectional risk that is social, spatial, that has to do with power dynamics, and really crosses all the social determinants of health and any socio-ecologic framework that we'd like to couch it in. We have to know that not only are there inequitable impacts, but there is inequitable access to interventions that can both protect from impacts and also promote recovery and resilience. So just a little bit about my story. I guess I was lucky enough to finish my M.P.H. And start working right when Hurricane Isabel made landfall along the North Carolina coast. And so we had since Hurricane Floyd had impacted North Carolina, we had started to have the bioterrorism grant funding. There had been a lot of effort in building our public health preparedness system. And so we did have measurable outcomes that were better in the 4 years where investments had been made. So from simple things like we had, contact lists of nurse consultants that could work in shelters during hurricanes, to more complex things like the development of 7 regional preparedness teams were available to conduct rapid assessments like CASPER's and directly provide technical assistance to local health departments. And there were other improvements in communication, partnership, and organization. And so having the chance to be part of this CASPER, having just finished my M.P.H, was really sort of a turning point for me, because it was the first time that I started thinking about doing a Ph.D. and what I would be interested in researching. I actually did my Ph.D. in Eastern North Carolina looking at a hurricane. But so that was really sort of my first taste of of CASPER and rapid assessment. And I guess I must have really liked it because I'm still doing it, 20 years later. So while I was at UNC, we did a number of CASPERs in close partnership with state and local health departments. I think that it is a consideration what your public health structure is in the state or region where you are located. So there is actually a fair body of research on the effectiveness and the differences around preparedness outcomes in centralized states versus decentralized states. But you are where you are, so just being knowledgeable about the way that the public health system is structured. So this was a quick response grant that we got from the Robert Wood Johnson Foundation to assess barriers to receiving the H1N1 pandemic influenza vaccine. So that was, seems like a lifetime ago, but was an interesting, I think, application of the CASPER method. It wasn't in response to a disaster per se, but the development of a novel vaccine and questions that the state health department had about potential demand for that vaccine once it became available. And we partnered again with the state and local health departments looking at coverage of potassium iodide distribution in an area of the EPZ, the emergency preparedness zone around a nuclear power plant. And I'm going to give just a few examples because I really want to show how flexible many of these methods are. And so we used our sampling frame as this 10-mile radius of an emergency preparedness zone. You can see it there in the circle. So there's a lot of flexibility depending on what the objective of your post-disaster assessment, or in this case, pre-disaster assessment is. And so we were able to find that there was very low household coverage. So very few people had KI on hand, but they also were not very concerned about there being a nuclear accident. So that found a gap for the state and local health departments to address because people didn't feel that it was a problem if they didn't have access to something, if they didn't have any concern about it. So this was another North Carolina CASPER, and this was an evaluation study. So again, I just tried to pull some different types of examples. So reverse 911 call system was activated in response to some wildfires. And there was interest at the state and local health department level to determine how effective that was as a preparedness measure. And so thinking about this coastal area of North Carolina, you need to know how effective that is. So if they should be implementing that type of notification system when there's hurricane evacuation, for example. And so this was another case of sort of a unique sampling frame, which was census blocks with at least 3 weeks or 21 total code red days. So that ensured that they had a significant exposure to the wildfire. And, we can think about exposure misclassification, which is a big problem sort of methodologically in disaster epi, I think. But so that was sort of another type of evaluation use of CASPER. When Hurricane Irene came to North Carolina, we were able to get a National Science Foundation quick response grant. And I'm going to talk more later about funding for some of these projects and look at several different questions: evacuation, perceived and actual flood risk. And with all of these, and I think I've said it with each one, they were all a partnership. The local health department, the state health department, the academic center, we all wanted to do this, and we all worked together to develop the objectives of the CASPER. So this was not a sort of parachute disaster epi with a group of us coming into a community and going out into the field. This was a lot of local engagement with local people being on each of the survey teams, with students from our graduate school in public health, and with students having an opportunity to see that applied research like this could be used for things like master's theses. It could be published in the peer-reviewed literature. That this type of interest in this type of research was not sort of an anomaly that would mean, you know, you couldn't go on into a career in academic public health. So I moved to Texas and I love this picture of Bastrop. If you've ever driven out of the Austin airport and south, you will recognize this road. And so there were very severe wildfires in Bastrop, Texas, an Austin suburb in 2011. It was one of the driest and hottest years on record. And a lightning strike started this fire. The conditions are certainly appropriate for this kind of disaster to occur again in this region. And so what was really unique about this, and the reason that I bring this up, is that in 2015, again, this was the regional health department, Region 7, that served a group of counties there. They came to us at Texas A&M and said, we want to do a longitudinal CASPER. We want to see what's changed since we were there. So if we did a CASPER right after the wildfire and we collected information on mental health impacts or on access to services or on preparedness planning, evacuation planning, did people change their behavior because of their experience of the wildfire previously? And so this was a relatively new use of CASPER to think about using it longitudinally. And so you can see in the left the census, the clusters that were selected in the 2011 CASPER and the ones that were selected in 2015, overlaid again with the fire perimeter, which again, I think accentuates the flexibility of this for post-disaster assessment. And then subsequently in, I guess, 2018, following Hurricane Harvey, the picture on the right is a group of trainees that we worked with who conducted in 5 jurisdictions in Texas, who conducted post-Harvey recovery CASPERs. So an event as large as Harvey really had a very long tail of recovery, not only for Houston metro area and some of the more highly populated areas, but also for some of the really rural areas that were impacted. So while I will talk a little bit about some of the sort of quote unquote rules of CASPER, I think that throughout the 20 years that I've been working in this, I've always tried to focus as much as possible on the flexibility, because it can seem overwhelming as a public health practitioner to think that, you know, oh, I need to follow this, you know, huge method that I don't really know anything about. So I think I'll just, you know, go to the health fair and have a convenient sample. We can do so much better with just really incrementally more work. So again, applying CASPER beyond disasters, we did several local health department assessments that we partnered to do CASPERs related to risk factors for Zika. And again, this was for the health department to have information to guide the development of educational materials, to guide the development of other interventions. And so the risk factors for mosquitoes are really simple, right? So you have those 4 things that you need to do: avoiding dusk and dawn, using a DEET, wearing long sleeves, and dumping out, you know, pools of water, pet dishes, or flower pots, or whatever. So it was a relatively easy and quick thing to assess using CASPER that could really help the health departments focus their intervention and education activities. So again, just different ways of seeing how CASPER goes really beyond that idea of disaster response. And it can be great if you're interested in CASPER to have an opportunity to practice it in something that is not an emergent situation, because it gives you more time to plan. and think about your objectives and your sampling and all the other things that you need to think about without it being kind of, okay, we need to be in the field and 24 hours. So this sort of original idea of CASPER is that the data would be available 72 hours after it was safe to enter the field and the area that was impacted. So I think thinking about using CASPER in different settings can really prepare you for using it when you have an emergency. And even thinking about how, with the FEP grants, people frequently would use the required exercises as a way to say, exercise your pandemic plan by having a seasonal flu clinic or something like that. So you can think about multiple goals that could be met with conducting a CASPER. So I moved to Delaware and have done several CASPERs here. I'm going to talk about just this one right now. We were approached by an environmental justice community just over the border. Part of the sample was actually in Delaware and part in Pennsylvania. And what had happened is the community had a large incinerator located there, and because of some policy and trade changes that had happened internationally and at the federal level, they felt that their community was being inordinately impacted. So basically, more recyclables were being burned there because they were no longer being accepted as exported from the US by other communities. And so that was the concern that was brought to us. And so we worked with the community to develop the objective for the CASPER. And this was different, I think, because for me, because it was a policy-based CASPER. And so we had sort of these global scale changes that were impacting an environmental justice community. And they wanted data to be able to advocate and provide evidence to sort of an anecdotal suspicion that things were happening differently. And so this was a really different take on CASPER, for me anyway. And so two tools that I would really encourage people to look at. You don't have to start from scratch. Doing a CASPER is not insurmountable by any means. The CDC CASPER Toolkit is available online and will walk you through literally every single step of conducting a CASPER, from setting your sampling frame to analyzing your data. And another tool, a group that I'm involved in that may not be as familiar to others in applied public health, is the National Institute for Environmental Health Sciences supports the Disaster Research Response Program. And so part of that program is a huge collection of validated questionnaires and survey tools and a lot of other resources that can be used for collecting perishable data in a post-disaster setting. And so it's also a great place to find academic partners who work in this space. There really aren't that many of us, but we all contribute our materials to this collection. And so it's a great place for you to not only find resources, but to also find contacts that might be able to help you with your own interest in collecting data. So I've presented all of these projects, and it's easy to look back and say like, oh yes, this CASPER was a success and this CASPER was a success, but it is not without challenges. So over the years, we have really, I think, tried to hone in on some of these challenges that I think are most important to consider before engaging with an academic or a state or local public health partner and thinking about doing this kind of either post-disaster data collection or sort of pre-disaster assessment or evaluation type of data collection. And so I've summarized them in these 5 categories. So I'll sort of briefly give an example of them. I think we can all certainly appreciate that timing is difficult. If people were just sitting around with lots of excess public health emergency capacity, I think we would all be living in a parallel universe. But there are other questions related to timing that are important to consider. Really relying on existing collaborations. So even back to 9/11 and the initial public health emergency preparedness, one of the mantras was always don't exchange business cards at the emergency. So maintaining those partnerships that may have fallen aside during the pandemic because everyone was so busy or so engaged with jobs that were outside of their typical scope or roles and responsibilities. Important to re-engage those if you think that you're interested in doing one of these types of assessments. What are the priorities? They may be totally different for me and a community member or a stakeholder, so we'll talk about that. What do you compare the CASPER data to? Like, how do you characterize the change that you're measuring post-disaster? And then what do you do with the data? Like, what's the translation of this research? So again, I just want to talk for a few moments about each of these challenges. So timing, one thing that has been really clear since I first started doing this work is that if your disaster happens over spring break or final exams or some sort of timing within the academic calendar, it can be really hard to get students and faculty engaged in your project. And you can't really always be sure that your disaster won't happen in that time. But academic practice collaborations, they require time. And so that can be something that can be difficult to maintain in the day-to-day busyness that we all have. It's hard to do this during a response because, again, people are in new roles and responsibilities. People have maybe been pulled from their typical functions. And so the collaboration is essential. So from an academic perspective, and in some cases in a practice setting, getting an institutional review board or some other kind of ethics review can be something that you can do in advance. And the DR2 has a lot of resources for how to do that. And even though we're doing better, I mentioned a couple of different sorts of quick strike type grants we've gotten to support this type of research. From an academic perspective, the funding cycles at NSF and NIH are simply too long. Even though they're much better than they used to be, they're simply too long to provide financial support for collecting post-disaster data. So even the rapid mechanisms from NIHS or from NSF would still be, maybe a 2 to 6 month delay before you found out if you had the money on the academic side. And so I think that one thing that's happened is that people will go collect data and then hold it and maybe wait to see if they get funding before they analyze the data. And I think that's really problematic from the community perspective. If I give people, a sample of my water, my soil, or a swab from my cheek, I don't expect them to just store it until they find out if they get a grant or not. I expect to find out, do I have a health impact from this? So there's a lot of interest in making those funding cycles more rapid. But I think that it is a challenge from the academic side. And I've worked a lot with health departments, but never in a health department. So I don't know what the funding flexibility there is in terms of identifying some funding rapidly to redirect resources to do a post-disaster assessment. So one of the other things about timing, so this was after Hurricane Harvey, everyone was in the field. The New York Times was collecting water samples. You can see on the right this list of stakeholders who were participating in DR2 phone conferences. And you had universities predominantly located in Texas, but also from, as far away as the University of Washington and Stony Brook, New York. So the sheer number of institutions, agencies, and individuals that were on the ground trying to do post-disaster data collection was really difficult. And the Houston Health Department really stepped up and played a coordinating role in that, and they asked that people share with them the types of data or samples they were collecting and the locations where they were going, so that certain neighborhoods who had been impacted would not be continually surveyed, continually asked to provide samples. And that worked pretty well, in part because there had been some exercises and people had a chance to work together just a few years before Hurricane Harvey happened. But it was still a really complex time to be on the field there, on the ground there. So I mentioned previously existing collaborations. So this was some of our students after Hurricane Harvey. And so, when I found these pictures, I thought, well, if you looked out the window of your house and you have, and for drainage, many of the minority and low income neighborhoods in Houston have open ditch drainage instead of concrete culverts. And you looked out and you saw a couple of students, laying in your yard, taking samples from your ditch, you'd probably be pretty annoyed, to put it lightly. But luckily, we had great on the ground partners. You can see in the right, one of the community leaders who was saying, these are the places that you should go. And so that really is incredibly important. It's very time consuming to both develop and maintain those relationships. And I'll talk a little bit later about how I think COVID has really complicated that further. But it's really essential. Even I think as a state or local health department, you really can't go into communities post-disaster to collect perishable data without strong relationships with community partners. So one of the other issues was thinking about shared priorities. So right after Hurricane Harvey, the Houston Health Department approached us and said, people really want to get back out to the parks. There's been some research showing that parks provide mental and physical health benefits after a disaster. We want people to get access to these parks. But there was a concern because you can see in this photo that there were literally thousands and thousands of tons of sediment that had washed down into the parks because of the flooding associated with Hurricane Harvey. And so there was a concern from communities, there was a concern from the health department. Would these parks be safe to return to once the water had gone away and this sediment had been hauled away? And so that was something that was very easy to identify a shared priority. We did both longitudinal soil sampling as well as surveying in the parks, and then key informant interviews with some park users, and really got a much better understanding of the perceptions of the people using the park, what they felt was quote unquote contaminated, and what they felt the health risks were to that, and almost, and as important to what interventions they were willing to do to protect themselves from that. So I mentioned baseline data. It's tough, right? We don't have data from everywhere where there is a, going to be a disaster or an emergency. So I mentioned before the BASTRP assessment. And so this was an instance where we were able to look at the post-disaster baseline after the 2011 floods, and then compare that with, 4 years of recovery. And so you can see there, like in the first line, the sleep disturbances that were reported by households as part of this CASPER were significantly lower in the 2015 CASPER as compared to the 2011. So in that instance, we had a prior CASPER to use as baseline data. There's a growing interest in things like urban gardening, although there's very little soil testing going on in urban gardens. So engaging, many of the Superfund research programs have done this. At Texas A&M, we've done this. At the Duke Superfund has done this. And so engaging with a partner in a non-disaster time to take samples from areas that would be of interest in a post-disaster time is something for which there are a lot of resources and people who study that. So then this other image is sort of a mobile collection unit driving around, taking air samples in sort of quote unquote non-disaster times. I would say always inter-disaster periods, right? We're always just in between disasters. And then there are a number of data sets that can be used to think about baseline data, the risk screening environmental indicators, the TRI, the Toxic Mobility Vulnerability Index, the EnviroScreen, for which we had one that was specific to Houston, Galveston. So you may have to be a little bit creative with your baseline data, but you can find some to use. Research translation, I think, is really difficult. The incentives that we have as academics are completely different than the incentives that people working in applied public health have, or as community advocates have. So, you know, we want to publish papers and present abstracts at conferences, and that we have to be really careful that that goal doesn't get in the way of letting communities know what's going on there and what the risk they might face is. And so one way that we've looked at research translation is maps. Maps can be a really accessible way for people to see, you know, sort of what group they fall in. So this map on the left is residents who attended community events after Harvey that were focused on recovery. And if we could overlay that with the areas that were most socially vulnerable or most likely to have flooded. And then, you know, the map in the right is just, I think, something that really brings attention to the idea that it's really hot in Houston, but it's very, very hot in a number of places that, you know, also have other types of crossovers. So one of my most sort of aha moments in doing this, we had a community partner in Houston, and we were presenting some data to them on contamination after Hurricane Harvey. And they asked us if we could redo the maps by city council district, because they wanted to take the data to the city council member and use that information. And, you know, we had never thought, we were like zip codes or neighborhoods or census blocks or census tracts. But until somebody said, do it by city council district, you know, that wasn't part of our thinking, but certainly easy enough to do. So what kind of information people need and how do they need it is something that, you know, again, is not part of our incentives as academics, and probably not part of our training either. So I wanted to talk a little bit about the most recent CASPER and modified CASPER that I've been part of. And this was a set of CASPERs that we conducted last spring in Delaware. And again, working with the state health department, they identified these tracts of concern. You can see outlined in, I guess, fuchsia there in the map, that were identified because they were part of the Health Opportunity Index census tracts, which are part of the State Health Improvement Plan. And they also had high levels of social vulnerability as determined by the ATSDR CDC SVI tool. Additionally, compared to the state as a whole, they had comparatively low COVID-19 vaccination coverage. And so the objective of these CASPERs was to address needs and concerns during COVID-19 to gather information that could be useful for the response to future outbreaks and public health emergencies. And so I think this is an interesting example because it highlights some of the flexibility of CASPER and how you sort of have to, roll with it once you're trying to do rapid data collection in the field. So we were planning to start going out in the field in January of 2022. And as many of you remember, we had a very large COVID surge. And so we actually pivoted the surveys to mixed methods. So we did a multi-week mail-in and online survey campaign, and then went out to the field to do the more typical sort of CASPER door-to-door household interviews after that surge had subsided a little bit. So another alteration that happened with these CASPERs or rapid assessments was a modification of CASPER in that these tracks of concern, as we might expect, and Delaware is a very small state, were already clustered. So we didn't need to use the CASPER sampling approach, the two-stage cluster sample, because we already had our sampling frame was already clustered. So we were actually able to use a random sampling approach because we were able to access a complete census of the addresses within these census tract boundaries. And so I think that was an example of how there were a couple of really major modifications that happened really quickly in response to what was going on in the ground. But ultimately, the goal was to get that information for the state health department, and the types of information that were fairly consistent across the 3 counties were that it was easy to access testing and vaccination, that it was easy to avoid exposure unless you had an essential job, but that there were really high levels of concern about people who lived in households with people with comorbidities. And so that message about the enhanced vulnerability of people to a severe infection was important there to think about. And so thinking about different messaging that might change to that. So one example of a change in messaging and something that was very prevalent in this is that people really, a lot of times in CASPER, we asked about people's preferred source of information. And it was very strongly noted in these assessments that communication had to be from a trusted local resource. And one example of that was for vaccine uptake among, at this point, only 5 to 11 and 12 to 15-year-olds were eligible. But that they really wanted that message to come from a healthcare provider or a primary care physician. There was also a really high level of concern about school needing to go back to virtual or hybrid. And so we thought that may be a leverage to, encourage people as well to get their kids vaccinated. And there were also relatively large number of households that had misconceptions about whether they had to pay for the vaccine or whether you had to have insurance to get the vaccine. So I think that we were able to identify some action items for the state health department. But I think that this is one of the things I wanted to come back to in thinking about how important the partnership piece is for doing any of this type of either preparedness assessment or post-disaster assessment, is that we have really strong a community engagement relationship through our Partnership for Healthy Communities here in our College of Health Sciences. Long-standing, very intentional partnerships. But when it came time to do these assessments, as engaged as the host sites were in supporting the process, people were so overwhelmed and burned out from COVID that it was very difficult for them to engage, even though it was something that they felt was needed, that they saw the outcomes were a good match for their priorities. So I think that coming out of COVID, we have to think a little more carefully about engagement. And we definitely have to continue to always pay attention to this persistent feeling among communities that data are collected but never acted upon. And that's been one of the biggest criticisms of CASPER and other rapid assessments for the past 20 years, is how actionable are the data. And so a few evaluations of large groups of CASPERs have been done to try and document actions that were taken based on the data, but we still have more work to do, I think, for that evidence base. So as much as I think this is exciting and everyone should go out and start planning their CASPER right away, I really, really do. I think that there are some really important remaining challenges to just be very clear about upfront. And going back to that one, what does community engagement look like post-COVID? It's been great in some ways. We've had community members able to attend trainings or workshops because they can get on Zoom and they don't need a babysitter. But we also have to acknowledge that perhaps different types of people or groups of people are attending virtual engagement opportunities. So that may be different for academic institutions and public health agencies. It may be the same. There's been a high level of distrust, I think, that's been fomented among, how many people and any institution, including academics and public health agencies, but that may be more intense for public health agencies. And I think that we have to go into communities now knowing that we're being held to a higher standard. People have been through a lot, and to engage and spend their time on something like this, it really has to be a priority of the community, and we really have to prove that we are going to provide feedback to them, return their data to them. I mentioned this just now, but what do we do? So like everybody loves to go do field epi, or at least I know I do, and my students do, but what do we do with the data we collect? Again, this has been a criticism of CASPER for a long time and other rapid needs assessments. We need more evidence of specific and measurable benefits, actions, and changes to planning and policymaking that have happened as a result of the data we collected in CASPER. Full stop, we need to do a better job of that. Because probably, at this stage, the resources that you need to go and do a CASPER or similar type of assessment, just doing it to raise awareness probably isn't enough. There's a lot of other channels that you can use, social media, other things to raise awareness, much more cheaply and in much less time-consuming way than doing a CASPER or another type of rapid assessment. I really feel like these are a heavy lift in some ways, but they're also really energizing. I've never had a student have a chance to do a CASPER that didn't come back really exhausted and really revitalized about having chosen to get an M.P.H. So we know we need more students in our applied public health and public health practice workforce pipeline. So I think that the engagement of academic partners, and particularly the opportunity for students to do this kind of field work, can really excite them about the possibility of a career in public health. And I think that's really critical now more than ever. The idea that CASPERs need to have a return on investment is obviously important. Again, when we had a lot more public health emergency preparedness funding, people were able to kind of creatively say, okay, well, we need to do an exercise, so let's do a CASPER, and we'll, figure out a way to meet a lot of different objectives from a grant or another sort of thing by doing a CASPER. So doing something like this as a one-off isn't that great of a use of resources, because maybe a year later when you actually have the hurricane or you have the wildfire, do you still have any of those staff that have been trained and done this? So you have to really think about this. I think, how do you balance this as a longer term investment for your health department? Again, going back to it again, I feel like I must be really worried about it because I have it in here like 3 times, but what we need an evidence base for public health emergency funding. The National Academies published a commission report in 2020. Unfortunately, I think it came out around July of 2020 when we were all really focused on something else. But the main thrust of that report was that we simply don't have an adequate evidence base for much of what we do in public health emergency preparedness to justify the continued investment in the systems that we built. So that is on each of us to really think about how what we do strengthens the evidence base for this, so that we don't end up in this sort of feast or famine type of funding situation around emergency preparedness. And then I think that you always have to think about this, and I started talking about this with an equity lens. So people are going to be concerned that if you're coming and collecting data, that something that they don't want to happen is going to happen. So whether that's green gentrification, whether that is an EPA buyout, whatever that is, have to think about the unintentional possibility that the kind of data you collect may contribute to a growing health inequities in communities that are impacted by disasters. So those are just a few remaining challenges. I'm sure there are more. I still continue to believe there are far more opportunities than challenges with this work, but I look forward to your questions. Here's my contact information. I'm sure it's in some of the materials, and I am absolutely always happy to talk to anyone about doing a CASPER, to direct anyone to any resources as well. So let me stop sharing and move on to, I haven't been watching the chat, but I know there's some questions in there.
So let me just speak for just a second. Thank you for a great, interesting talk, Dr. Horney. That was really, great, inspirational, really. Some of your experiences are just really nice, very positive. While we're collecting some of these questions, and there have been some questions and I see a lot of thank yous popping up, and I agree, and wonderful presentation is another one. But while we're collecting some of those, I had one I didn't catch that you touched on. I apologize if I missed it, but it's more of an on the ground, out in the field question. And I know you've just had probably more experience than certainly anybody outside of the CDC group, if not worldwide, with this. What do you do about people non-response or people not being home and those kinds of issues, participation? Do you have any general guidance that you try to share with your teams and that you could share with us?
Yeah, so my shorthand guidance is get your EID and your communicable disease nurse and all those people out there, because they can get anybody to tell them anything. So making the teams is kind of a real like nitty gritty kind of thing to do. But We did a paper that we reviewed the contact, cooperation, and completion rates of CASPERs. And it's actually not that bad. I guess we really were worried in the post-COVID ones that we just did this spring that, it would be sort of a whole new world and people would just be like, I don't want to talk about COVID and I don't want to talk to you. But even with those, we had really high completion rate. So the completion rate is like the percentage of that 200 or 210 surveys that you complete. And we had relatively high contact and cooperation rates. So you've got to do some basic things like, go on weekdays and weekends, go in the day and the early evening. Lots of things to think about with like daylight savings. There's that golden hour or 2 hours between like 4:30 and 6:30 when people are home from picking up their kids and they haven't started dinner. And, you can get a lot, but in the winter it gets dark really early. And so that would be a safety concern. So thinking about those kinds of things. And again, we have found over years and years and dozens of CASPERs that an interview team that has an ideal interview team has a student and a public health staff member or a community member. The students are great at like working the GPS and, shuffling the forms. But like I said, it's kind of a joke, but if you can do DIS or you can be a communicable disease nurse, you can get people to talk to you. So, there are some communities where we really think about, we look at the census data and we say like, okay, there's a pretty large share of Spanish speakers in this census tract. So we're going to make sure we send Spanish teams there. So really small things, but that add up to making it so that they're actually, I was kind of surprised post-COVID, but it still works pretty well.
Yeah, that sounds like really good practical advice and ways to maximize your response. Very good. So a couple of questions have come in. Let me just read one or two to you and get your reaction and response. So one of the early ones, so this is early on in your talk, I think. You referenced in the longitudinal study that mental health focused questions, including access to treatment resources, were included. Were the mental health questions included in the original CASPER or more the focus of the follow-up?
Yeah, so they were included in the original CASPER. From the wildfires, it had just been like tremendous community devastation. People lost a lot of farm animals. People were, it was just like swaths and swaths of devastated. And which, I'm sure many of you working in the West now have seen this, more and more. But so those were part of that. So one thing that you can do that we have done in CASPERS is to get a question from maybe CRAMS or BRFIS. So you have an already validated question, and then you can compare your responses to, maybe your state or whatever kind of prior data that you have. So we asked those questions. That was a major concern after the wildfire, so much so that the health department actually got a large grant to extend the provision of mental health services beyond the sort of FEMA 1-year cutoff. And so that was a focus of both the post-wildfire and the recovery assessment.
Thanks. Another question came in about using wastewater results, maybe in addition to or to complement any of the CASPER results for either COVID or other infectious disease?
Yeah, I haven't seen those two things married together in any way. We definitely had that data here in the state, but it wasn't something that we were looking at. I think that would be more of a, rapid response type of thing, because that would, I think, be more perishable, right? So we had long trajectories of that data, but it wasn't ever, I've never seen it being married to community assessment data, although you can imagine, you know, how maybe verifying some sort of sample of people in an area that they had actually had COVID might be interesting and add
sort of a validation result,
Yeah.
perhaps. Another question came in about reimbursement. Can you talk about your policies or ideas about reimbursement for CASPER participants?
Yeah, so for many years, I think we've mostly done things like, you know, pass out educational materials. So when we've done CASPERs about seasonal flu vaccine coverage or H1N1, we're, you know, giving people maybe a bag from the health department that has a lot of flyers in there about where will there be vaccination sites, you know, maybe a hand sanitizer or, you know, some sort of very small thing. Maybe one of those reusable shopping bags, you know, with a lot of flyers from the health department. In the Delaware CASPERs that I discussed, we offered $30 gift cards to anyone who participated. And actually, we ended up having a lot of people who didn't want the gift card. So all they had to do was provide an email address to get an e-gift card. But I would say, you know, probably half the people who completed the surveys just said, I don't need it or want it. Or I don't want to give you my email address for it. So it can be educational. I think one of the first things that happened in that North Carolina CASPERs back around 2003, 2004, that was very eye-opening is that one of the questions on the, and you'll see the CDC sample surveys, they have a selection of them in the toolkit. And one of the last, I think the last question was sort of, what's your greatest need now? And so I think we learned a lot about that because we would ask people and they'd be like, oh, I need a tarp. Oh, I need water. Oh, you know. And so, but then you were sort of like, oh, okay, well, I don't have any of those things. So thanks, you know. And so what's the, so at least you need to know if someone says, I really need a tarp, then you need to have on hand, like, here's the 3 places that are handing out tarps, or, you know, here are where the water buffaloes are where you can go fill up your things. So you got to really think about that, you know, asking people what they need and then not having anything to provide is, you know, it's not a great.
Right, have to be careful there. Thank you. And another question came in about publication and in particular about your mixed methods. Have you published that or do you plan to publish soon?
So we wrote for those, the mixed methods ones, we wrote reports for the state health department and I don't know when or if those will be published. We based that on an assessment that was done in a similar way, a regular CHA, CHNA that was done in Chatham County, North Carolina, using those same methods. So if Laura Lee, if you want to put your email in the chat, I'll be happy to send you some information on that. I don't know when those will get published, but I could certainly share with you. We ended up getting somewhere between 10 and 20% of the responses done either via mail or online before we went out to do the CASPERs. And so, you know, that was useful. And I think we really couldn't send people out during like a huge surge in COVID. So, right.
Because this person was interested actually in replicating the results or using them and trying to replicate. So some interest. And then the last question I have here is, have you had any experiences communicating your disaster response research to the segments of local government who do land use planning? For example, lessons learned in disaster evaluation that could influence appropriate zoning for land not yet developed.
Yeah, so we've actually, I guess I didn't include any of them here, but we've actually used CASPER's. I've done a lot of work with urban planners around, mostly around recovery planning and hazard mitigation planning. And, you know, so we've asked people more about their engagement in some of that planning, or their awareness in some of that planning, or what types of maybe action-oriented mitigation. So, you know, would you be supportive of stopping development or buyouts or different sorts of action-oriented type things to happen there? So it had definitely has been, but I think probably that connection, you know, those were like intentionally done in partnership with urban planners. I think in terms of more general, like, you know, in terms of a flood or a hurricane, we probably haven't done as good a job sharing that that piece, but yeah, definitely have. And Olivia, I think that was your question. Again, if you want to send me an email or put your email in the chat, I'd be happy to share some of those examples with you. And so I think you can at least find out, you know, what sorts of interventions are most acceptable to people, and what kinds of engagement opportunities they would like in terms of engaging with those planning prioritization going forward.
Okay, great. Well, thank you. So thank you for your great presentation and your time for the Q&A session. And
Dana, can I just answer one more just popped in about
oh yeah, sure.
mixed method. So yes, we did do a QR code. So we actually mailed we did a series of mailings. So we mailed a postcard with a QR code, a reminder postcard, and an actual survey. So the postcard with the QR code directed people to a Qualtrics, where they had an individual, it's tough with like bots and things like that. So you have to do a little bit of work on the front end to make sure, especially if you're giving people $30, you don't want them to just be able to, like, you know, keep taking your survey. So Louise, I think that was your question. Again, like if you want to email me, I would be totally happy to, you know, give you a copy of the postcard so that you could see what was on there. We have it in Spanish and we have it in Creole. And yeah, I mean, that worked pretty well. Again, we got 10 to 20% of our responses done that way before we sent people out. So that, you know, that really probably saved us a day of surveying in the field. So.
Okay, we do have the Q&A, the roundtable session this afternoon. So you can follow up with any additional thoughts that you might have too, Dr. Horney. So let me remind everyone that, that we have the roundtable with Dr. Horney starting at 2:15. I got that right? Yes, 2:15. And next, coming up after a short break at 1 o'clock is Dr. Goodman on cancer cluster investigations, a few thoughts and suggestions. So again, thank you, Dr. Horney, and hope to see you all back at 1 and then again at the roundtable.